Vitaly, take us through a multimodal regimen for your patient who comes in and says, hey doc, I'm 6 months after my rash, my lesions have healed, I have a little bit of scarring, but I can't put on a shirt, and I can't touch my skin, and I'm not sleeping at night, and life is terrible. What are you doing for that patient?
Before I even go into this, I want to add to the risk factors a clinical anecdote. A colleague of mine who works in the same department is an absolutely healthy anesthesiologist who was rendering care in Haiti during the, obviously, the tragic events that were there. And he was working day and night for several days. He developed postherpetic neuralgia, he developed shingles and postherpetic neuralgia in V2 distribution, which was very disabling to him. He recovered quite well with the treatment with the medications that have been mentioned here. Getting back to your question, when I see the patient in a tertiary medical center, obviously these patients have been already tried on some of the medications that have been here mentioned. And some of the first agents that have been tried by other physicians before they come to us were medications from gabapentinoid group, such as gabapentin or pregabalin. I see more and more often patients who have been tried on topicals, and typically it's lidocaine patch, 5% lidocaine patch. It somewhat, as Charles mentioned, the most common dermatomes that are affected are thoracic. So for an elderly female who is, let's say, widowed and lives by herself, it's sometimes quite difficult to apply a lidoderm patch on her back. It requires certain dexterity. So I look at the patient physical status, how vigorous she is, other medications, whether the patient, let's say, is an elderly male who has benign prostatic hypertrophy. Would I want to start this patient with a tricyclic antidepressants, which can be very helpful for sleep and pain, neuropathic pain especially, of course, but can cause orthostatic hypotension and urinary retention. So you have to factor in, I'm just using this as a clinical example, which things you want to factor in. Then, of course, there are such hurdles that we have all to use. Let's say I want to order a medication such as duloxetine to improve the neuropathic pain and improve sleep, but at the same time, let's say the patient who is on Medicare might not get this medication be approved by his insurance. I try to combine adding one medication, systemically acting medication, with a topical at a time, and move very slowly, especially with the elderly patients. But again, I use gabapentinoids, I use topical agents, antidepressants, especially those I want to emphasize, which have a property of norepinephrine reuptake inhibition. Obviously, antidepressants can be helpful for sleep and mood, but those which do not have norepinephrine reuptake inhibition are not proven to help with the neuropathic pain.
So at this point, we've talked about a number of potential treatment modalities, various forms of gabapentin and pregabalin, carbamazepine. We touched on opioids, topical lidoderm patch. But Vitaly brings up a good point, Charles. Venlafaxine, is it as effective as duloxetine? Do we have any data if patients can't get one drug, can they use another SNRI-like mechanism of action?
So something that's really cool and more than just coincidental, although it was coincidental, the month, I believe April 2004 or March 2004, that duloxetine was FDA approved for diabetic neuropathy. In one of the major pain journals, there was a multi-center study published regarding the benefit of venlafaxine for diabetic neuropathy. And so the answer is yes, but there are some caveats. Venlafaxine, unlike duloxetine, which at the any dose basically is a dual reuptake inhibitor of serotonin and norepinephrine. At lower doses, venlafaxine acts primarily as a serotonin-specific reuptake inhibitor. And interestingly, that study in diabetic neuropathy, as well as a separate migraine headache study, demonstrated that unless you're at a dose of 150 milligrams or above, you don't get the analgesic benefit, because it's at that dose that it becomes a dual reuptake inhibitor.
I think that's a critical message.
So lower doses may not help as much as higher doses.
Yeah. You know, one thing we haven't